wherever you are in the world, in Africa, and especially here in Zambia. This is Frank on Camnet. And tonight, we're looking at various forms of cancer. The reason? This is Cancer Month. My guest, Dr. Louis BANDA from the Cancer Hospital. Doc, good evening and welcome to the program.
Good evening, Ambassador Mtuvira.
Thank you.
Thank you very much for having invited me to this
Thank
program.
you. I understand we were at school. Well, we went to the same school.
Yes.
In
Kalonga.
Kabwe.
Yes.
Very good school. I went to school there with some very famous, names. Some of them went to be, holding distinguished jobs in this country, like Janos Kapwasha. He later became a minister. Before we delve into this, subject, just briefly tell us about your development, throughout the university and why you chose medicine as your career.
Okay. I should say from the outset that medicine was not the number one thing that I wanted to do.
Right.
I'd wanted to become a farmer.
Mm-hmm.
So my number one choice was agriculture.
Yeah.
So I was meant to go and do agriculture. But when I was in Form 4, I had a medical issue.
Right.
Playing football, I broke my bone.
Yeah.
And then the bone got infected. So for a long time, I had problems with that infection.
Right.
And having to see a lot more doctors. Mm-hmm. And before that, I grew up with my grandmother, who was asthmatic, and she was ever in hospital from time to time. So I changed my mind, last minute. Let me just do medicine so that I can maybe understand my condition. Right. And also to help my grandmother. Mm-hmm. And that's how I ended up at medical school.
Brilliant. How did you cope? I ask this question because I got a couple of friends of mine who are doctors. One of them, I present a breakfast show with Dr. Tilele Mwansa, and I had asked her, I said, this is very frightening. We understand that you have to be mentally astute, you have to be academically strong, to eventually become a doctor. Run us through.
Yeah. So, to go through medical school, obviously, academically, you have to perform very well. Yeah. It was very highly competitive, I should say, that time. In my intake, you started from main campus in the School of Natural Sciences, and then you chose which school you wanted. So I chose medicine.
Yeah.
In our time, there was almost like 2,000 people applied to go into medical school. And it turned out that the class which was in third year then couldn't proceed, like a number of people couldn't proceed to fourth year.
Yeah.
So they just wanted about 33 people.
Right.
So out of 2,033, so we fought very hard. I managed to get into the medical quota, what they use they call it medical quota. Then from main campus, you go to Ridgeway campus.
Right.
And when you go there, in third year, you start, your actual medicine. At main campus, it's mostly chemistry, mathematics, physics, biology. And then you go to medical school, then you start the actual medicine. When you're doing the actual medicine, it's quite involving. You start learning about the human body.
That's right.
And then they introduce you to dissections of the human body. You have to understand the makeup of the human body.
Yeah.
You start studying anatomy. So when we went there, I had not been up and close with a dead body.
A dead body,
Yeah. So they take you during orientation. They show you how they preserve the dead bodies. They are from sizes of fetuses to adults. And then they had showed us, there were like 12 of them in the dissection room. So they say this is where you'll be doing your anatomy studies. And, they're covered with plastic because we use formalin.
Right.
And formalin is quite volatile, so you need to keep it, wrapped in a plastic. And that's how we started.
Absolutely.
The first day, we were so scared.
Right.
We were 3 of us in the room sharing. Me, Dr. Lishimpi, Kennedy Lishimpi.
Yes, I know Lishimpi well.
And Dr. Kachingachizia.
Yes.
Those were my roommates.
Yes, absolutely.
When we were in 3rd year.
Yeah.
So, then we go there. We start. The first part is where you have to take out the skin from the back.
Yeah.
So there was somebody who was repeating, and I should say he helped us a lot because he had gone through it.
Right.
So us couldn't even touch the blade and start cutting. So it was him doing that.
Right.
But later on, we were encouraged to start touching.
Yeah.
And that time, we never used gloves.
Incredible.
So we used bare hands.
Incredible.
And this is how we started. And now it's time to go and have our lunch.
Yeah. You're basically thinking about
it, and we couldn't eat.
Right.
And it was a lot of chicken, and couldn't eat the chicken.
Yeah.
Yeah. But later on, you start getting used.
Yeah.
They give you a box full of bones, which you keep. Like individually, you have this box to study osteology, the study of bones itself. Yeah. So you have to learn where these muscles are, are connected, which tendons are there, and the grooves of the nerves and all those things. So it's a lot of studying.
Absolutely.
And I should say that to be a doctor and to be a good doctor is lifelong learning.
Absolutely.
You can't stop learning.
Absolutely.
And there are new things coming on the scene every day. So you have to be ready to study. If you have to be a doctor, you have to be strong, strong-willed in terms of studying, as well as, being dedicated to what you do. So it's a lot of work, but it's something which you can do.
So at what stage did you decide that you wanted to specialize?
Yes.
When did you decide that you wanted to specialize?
So I decided quite early, when I was still a medical student.
Right.
I'd wanted to specialize. That time, the seniors who we had that time would tell you that it's better to be general and not specialize.
Right.
But I thought, through it, and I thought to specialize is better.
Right.
And if you specialize, you're going to, learn more, and then at least you narrow the field in which you are going to work.
Yeah.
And then it's very meaningful, and you can help society much more if you have specialized. So initially, I had to go and do internal medicine. So I'm a physician to start with. So I did 4 years, master's at the University of Zambia. And one thing that I had encountered during the time I was working as a doctor is that we didn't look after cancer patients very well that time.
Yeah.
Because there was just few doctors who looked after cancer patients, and it was out of, they just volunteered to look after cancer patients. Yeah. Not that they were trained into looking after cancer patients. So that's when I decided that there's very little that we do. I used to see so many, very advanced cancers, even on the medical side, and nothing is being done. So that's when I decided that I would also probably, go into oncology. And oncology is in different branches as well. So there's what you call medical oncology. So if you are going to do medical oncology, most of the time, you have to be a physician, and then you can go and do medical oncology. Or if you want to do pediatric oncology, which is specialized for looking after children, you have to be a pediatrician, and then you can go and do pediatric oncology. But we went and did what they call clinical oncology, where they've combined radiotherapy as well as medical oncology, which is chemotherapy. So you combine those two. So they found places for us, and this was with a view of opening the cancer hospital. Right. Were the first people, not the first people as such. There was someone else who was trained earlier on, but he was, not practicing that time. But this is a time when Zambia had decided that we are going to have a oncology hospital.
Yeah.
So we were sent, a number of us.
Yeah.
We went to Johannesburg. So we were like 4 doing oncology, and then there was like 7 who went to do radiotherapy. There was 2 people who went to do biomedical engineering, and then there was 3 others that time. 4 of them went to do to become medical physicists.
Right.
Because with radiotherapy, you need a physicist as well.
Yeah.
You know, to calibrate the equipment, making sure that you are giving the good dose, and also to do quality assurance on the machines. So that's how we went to South Africa. And it takes 4 years, another 4 years.
Absolutely.
So I've done 4 years as a physician, then another 4 years as a clinical oncologist.
Are you a full complement, staff of the various disciplines that you have talked about at UTH right now at the cancer hospital?
Yes, we are quite. We are growing by day. We've added more people. So, at cancer hospital we have we have the clinical oncologist. We don't have medical oncologists as of now.
Yeah.
We have clinical oncologists who cover for both. Like I said, they will give radiotherapy. They can give chemotherapy.
Yeah.
But we don't have a medical oncologist as such. Initially we had one, but was since left. And then we have the surgeons. So we have the gyne oncologist, and then we have the surgical oncologist, and then we have pediatric oncologists who we have currently, and then we have 2 of them, and then we have what we call nuclear or nuclear medicine physicians. So we have a number of them. One is based at Cancer Disease Hospital, and then there are 2 more who are based at UTH Adult, but they work together.
Absolutely.
Yes.
Before we break down the various cancers, Dr. Banda, the general, basic, important question, for the sake of our viewers in today, what exactly is cancer? What is the genesis of cancer?
So cancer, and it's a good thing that you said various cancers in the introduction. Cancer is not one disease. So cancer is a group of diseases. And the characteristic thing about cancer is that there is abnormal cells which grow uncontrollably, and then they start invading initially local tissue, and then they can go to distant organs as well, meaning that they can spread within the body. That's what cancer is all about. But it can start from any organs in the body, and we have hundreds of cancers. You can count them. There will be hundreds of cancers that one can develop, and the naming of the cancers will go by which organ they are coming from. So, for example, if it's coming from the brain, we'll say it's brain cancer.
Right.
Yeah. And if it's coming from the prostate, we call it prostate cancer. If it's coming from the cervix, which is the mouth of the womb, we call it cervical cancer. If it's coming from the womb itself, we call it uterine or womb cancer, like that. If it's coming from the bowel, it's bowel cancer. So that's one way of naming cancer, by site where they are originating.
Absolutely.
But there are other ways as well.
You talked about these cells, and how do they become abnormal? What triggers it?
Yes. So there's things that can cause the cells to become abnormal. The number one thing that can cause cancers is obviously in this region is infections. So many infections can cause cancer. I'll just give a few examples. Cervical cancer. Cervical cancer is caused by a virus, which is human papilloma virus, or the famous HPV. So once the cervix is infected, it will develop changes in the cells. So what happens that the virus will produce some substances which are going to cause some changes, especially in the DNA. Remember that the DNA is like a template for how the cells are going to replicate.
Absolutely.
And how they are going to, in which cells they are going to develop. So what will happen that the cell becomes like immortal, to continue dividing non-stop and controllably, and then to start invading others. So what happens that initially there will be those cells, there will be those so-called within the DNA. There will be those sections within the DNA that cause the cells to divide. So it promotes division and continued dividing. And then there will be those genes that stop, the cells from doing that. But that balance, the cells that are supposed, the genes that are supposed to control the divisions, they are impaired as well. Right. So we call them like tumor suppressors. They're supposed to suppress tumors. If there's any mistake in the DNA, the cell should not divide. It should stop and then it will die out, what we call apoptosis. But in the case of cancer cells, they don't listen to any of these controls. So they continue dividing until they develop into a mass. Initially, they will go into the local tissues, and later on, there will be more changes, then they can go into distant places. And then also, the cells encourage vessel formation to feed itself. So there's a lot of vessel formation within the tumor, and basically, this is how the cells will begin. But there will be, obviously, that probably what I'd mentioned, the virus that will cause this to change. And then it's the same thing that will happen, for example, if you are a smoker. There are all these chemicals, from the environment that can cause changes in the cells, especially in the DNA, and cause the cells to behave abnormally and controllably. And then even the radiation that we use for cancer treatment sometimes can lead into cancer. There's also things like being overweight, obesity, and sedentary life that we have now. We drive everywhere we go.
Absolutely.
And at Kwendo we get it. But that's not very good for health. Those who are obese, they tend to develop non-communicable diseases. They will develop hypertension, they develop diabetes, and they can develop cancers. Cancers like breast cancer is a result of someone being overweight. And then of the common causes that we know, smoking is something that should not be done, and it's something that can lead to a lot of cancers. Not just lung cancer, can cause throat cancer, it can cause pancreatic cancer, it can cause oral cancers, a lot of oral cancers, different types. And then, again, what we know is that, eating a lot of meat, for example, and especially processed meat, with nitrates within the meat, they are going to cause changes in the DNA and can lead to cancer. So people have to avoid eating too much meat, and we should include in our diet things like vegetables and fruit, because these, what they do is they have what they call antioxidant properties. And what we know is that things like meat are going to encourage oxidation, and then there will be changes in the DNA, and if you are changing the DNA, that's what will lead to cancer. And if you can avoid too much meat, especially like things like the disease like prostate cancer, probably is encouraged by eating too much meat. And if you avoid it and you took a lot more vegetable and fruit, you can survive. And then the other thing that we know sometimes is just the age itself.
Yeah.
As you go old, the chances of you developing cancers is much higher. Because remember that the cells divide and divide, and then they start making mistakes, you know, and then you can develop cancer. So there are multiple things that can lead to cancer, but basically it's those that I've mentioned.
Before you break down the common cancers in our country, you know, Doc, you did make reference to these cells being abnormal. As they become abnormal, what damage are they doing to the body and mind?
Yes. So what they'll do is, depending on the type of cancer, initially they will invade locally, say in the cervix. Remember, there's tissues nearby, so they'll start growing in the tissues, surrounding tissues. They can grow into the bladder. If the tumor grows into the bladder, it can perforate, ulcerate, and perforate, and there will be a communication between the cervix and the bladder, like that. Or it can grow backwards, go into the rectum behind, and make a hole in the rectum, and then it can go to other tissues. For example, or other organs, can go to the liver, and you know there will be sometimes multiple disease within the liver, takes over the functions of the liver, and you give complications, and it can go into the lungs, and probably if it's in the coverings of the lungs, you can have what you call pleural effusion, you know, and you know there's so much fluid being produced, and you compress your lungs. And that can result into death, sometimes because of reduced, you know, return of blood to the heart. It can even go around the coverings in the heart and make compressions within the heart, and can lead to death. Can go to the brain, cause all sorts of complications. You know, there will be swelling in the brain, and somebody can convulse. You know, the pressure within the brain can go up, and can cause all these complications. There will be bleeding because of ulceration. Most of these tumors result into ulceration. There's a mass effect of the tumor itself because it grows into a mass which is uncontrolled. It can compress, you know, tubes and, you know, within the body. For example, if it's in the lungs, it can compress on the breathing tube or the windpipe, and then you can't breathe, and you can die as a result of that. Or it can compress onto any structure. On the ureters, you find that your ureters are compressed, and then urine cannot come down. It can lead to kidney failure and dilatation of the ureters, and the kidneys can't function like that. So there's all these effects, you know, the pressure effects, there's effects of going to other tissues, and then sometimes the tumors can produce certain substances that can change the way the body is functioning, and can lead to tissues failing you know, with time.
Right. Yes. Before we talk about the people who are most, you know, prone to cancers, I think this gives you an opportunity to run through the common cancers right now in our country.
Yes. Yeah. So the common cancers in our country, as we see them at national level, even at Cancer Disease Hospital, is that the commonest cancer for females is cervical cancer. And the commonest male cancer is prostate cancer. So in the top 10, you find that cervix is number 1, followed by Kaposi. Kaposi sarcoma is type of skin tumor associated with HIV. And it was common those days. Nowadays, because of introduction of antiretroviral drugs, it seems like, you know, you rarely see it. The numbers have gone down. And then the next one will be, like number 3 will be prostate, and after prostate you have breast cancer, like number 4. Number 5 you'll have things like liver cancer, and then you start having things like esophageal cancer, you have non-Hodgkin's lymphomas, and lymphomas also associated with HIV sometimes. When the CD4 count and the viral load is very high, people can develop lymphomas. Various types of lymphomas, from brain lymphomas, from peripheral lymphomas as well. And then we have tumors of the stomach.
Yeah.
There's also tumors of the head and neck region, which are a number of them. It's not like a particular type of tumor. Yeah. So those will form like the top 10 among adults.
Right.
But for tumors in the children, we'll see like non-Hodgkin's cancer, non-Hodgkin's lymphoma, leukemias. There will be brain tumors. There will be kidney cancer, what is known as nephroblastoma. There's eye cancers, retinoblastoma. We see a lot of it at the cancer hospital. And then we'll have also liver cancer and the brain cancers, and also muscle cancers, what we call sarcomas in children. Yeah. So the tumors are not the same. Like in handouts.
They present differently.
They present differently.
Yeah.
Most of the children cancers are those that are hereditary. You know, that's the other cause, that you have just inherited these genes that are going to lead you into developing a cancer. Those are very common among pediatric cancers, and in adult cancers mostly is something that you acquire. Okay, and there are different causes, and cervical cancer due to HPV for sure. When it comes to Kaposi, there is another virus that you are infected with when you are still young, what they call Kaposi associated virus, or HHV8.
Yeah.
It's a type of herpes virus. And then for liver cancers, there's a number of things that can cause it. Hepatitis B, which is highly transmissible and is sexually transmitted in most cases. Hepatitis C as well. Most of these hepatitis E as well can do that. And then also the foods that we eat, things like groundnuts, and also mealie meal. Things that have been infected, like the grain which has been infected with some fungus. The fungus will produce what is known as aflatoxin.
Right.
And then that can cause, changes in the liver and leading to cancer itself. But, if you look at the causes of cancer, you discover that there are those that you can prevent, and there are those that, by avoiding, contact or by vaccination, you can stop some of these cancers.
I'll be revisiting the question of prevention, especially in cases of hereditary.
Yes.
You can perhaps intervene that. But before I do that, but you have alluded to the fact that there are various cancers.
Yes.
To a common person, how do I know? Because they present differently. So how do I know?
Yeah. So that is why we should have more of these discussions.
Yeah.
So that we can let the people learn. And there are various cancers, and what is good that the various cancers, they are commemorated in different months. And if we can take one cancer
every month, absolutely.
Yes,
yeah,
we can discuss the main cancers that are there. So so if it's say in the brain and you have a brain tumor or a brain cancer, obviously the features that you have will be referable to the brain. So you'll have things like maybe headache, confusion, convulsions, and then maybe you can slump into a coma. So if you see something in the respiratory tract like lung cancer, obviously you'll have things like cough, you know, difficulties in breathing, you know, and probably also like blocked, though you are failing to even take in air. If it's in the mouth, there will be, say, pain or a mass. So you can find a lump or a mass, an ulcer which is not healing in the mouth. Those are features of cancer. A change in the voice, you know, the voice change, you know, it can be a sign of cancer. You know, a change in the bowel habits. You know, human beings have these habits that they develop. You know, most of the time you go to the toilet a number of times, fixed number of times, then you find that you don't go to the toilet. Probably you have constipation, or you have, you know, changes from constipation to diarrhea. Then there's something wrong with you. And then bleeding from any place in the body, bleeding from the nose, bleeding from the mouth, bleeding from the alimentary canal, bleeding from the female or male organs, bleeding from the rectum. All these things can tell you that there's something happening, or probably there's something that is obviously that is causing you to bleed. And then abnormal discharge as well, you know, from the nipples, from the mouth, from the, you know, genital tract. All these things can point to cancer. And then also, you know, sometimes like masses, you know, any mass anywhere can be a cancer. And the only way you can tell that you are dealing with a cancer is to do the investigation.
Absolutely. I was actually coming to that. Let's start with the situation of hereditary. You know that, you know, your mom or your father, you know, had a certain, you know, cancer. At what stage do you decide to intervene, you know, and do an investigation? Talk about that, and also talk about those with compromised, you know, health.
Yes.
What interventions, you know, can they take?
Yes. So again, the way you can screen for these cancers is dependent on which cancer you are dealing with. For example, if you are dealing with breast cancer, which can be hereditary, and you find it that about 5 to 10% of the breast cancer is hereditary, and you know, those type of cancers, they tend to develop in younger patients. You know, in younger patients, and then you find that there will be a number of people in the family who have developed the cancer. Maybe an auntie, your mother, your grandmother, like that. And then if it's so, and it seems to be hereditary, there are tests that you can do. And for such people, you have to start doing your tests. Remember that you can do early diagnosis in breast cancer. You cannot prevent breast cancer, but you can do early diagnosis. So instead of starting at a time when we usually recommend, like at 40, probably you should start checking for the cancers 5 years earlier, maybe at 35. That's for breast cancer. And sometimes you have to examine yourself if it's breast cancer, and looking for lumps, for changes in the breast, you know, and obviously mammogram is what you can do, you know, and that's the best test that you can do. And when it comes to bowel cancer, which is also can be hereditary, is that you can check for any bleeding. If there's any bleeding, then you can do a scope. You can do a colonoscopy to check if there's any early changes, and this can save someone's life. I'm saying this because this is quite a common cancer that we are seeing now, the bowel cancer, and what we find it very late. Most of the people will have cancer spread to other organs, to the liver, to the lungs, to the bones, to the brain, like that. And how we can catch it early is that we have recommendations, say from 50, you should have a colonoscopy. But if it's in your family, you should do it earlier, like I said, 5 years earlier, you start checking for these things. So you can have a scope done and check for whether there's bleeding, you check for blood in the stool, much earlier. And then there are these genes that you can look for, like for breast cancer.
Right.
Is special genes that you can look for and which you can find like you have already. And these are going to predispose you to developing breast cancer. For such people who are high risk to developing cancers like breast cancer, probably this is where you hear people saying you can try to prevent the cancer from developing.
Yeah.
So there are various methods that they have used. You can use the chemical way. People have done surgeries on themselves to try to prevent. You've heard these celebrities who do surgeries, preventive surgeries. It's the same thing, like even on the uterus, they can do that as well. Yeah. So the hereditary cancers, if you know, you can check for these genes.
Absolutely.
And this is where things are going now.
Yeah.
And if you found those genes, then you can start looking for the cancers early, for the early diagnosis.
The other risky group, those the compromised.
Those ones, what we do is we have to look for all the types of cancers, like, for example, say you have HIV. Obviously, you are prone to, if it's female, they are prone to, to have changes on the cervix. You have to start looking for early changes on the cervix, and then you can try to treat those early changes to prevent them from developing, cancer. But this is controversial, but it's something that we do.
Yeah.
Okay. And the other thing that you can do is you can anticipate. For example, somebody who is on drugs that are causing your immunity to go down. For example, because of say you had the kidney transplant. These ones can develop cancers. They can develop Kaposi, the skin cancer. They can develop lymphomas and these other cancers. So you can anticipate that they can develop these things, so that you start looking out for these cancers. And then if it's retroviral disease, remember that if you start the treatment, you are going to prevent some of these cancers. Like I said, Kaposi, when you start them on antiretroviral treatment, you find that the rate of this cancer developing is much lower.
Right.
And this is what has happened, that you find that even this cancer is not that common nowadays, because we are treating the retroviral disease. But even for the other forms of immunosuppression that you can give as a result of, say, transplant, you can try to do early diagnosis and treatment.
Right. You're talking about diagnosis, in which extremely important.
Yes.
With all these cancers we have talked about, the million question is, how accurate is your diagnosis, and do you have adequate equipment to carry out, actual and correct diagnosis?
Yes, I should say that we have adequate, equipment. Why I say so is that, most instances we know by sight what sort of cancer it can be, but probably the human beings who confirm that this is this type of tumor, probably we don't have enough, the manpower that confirm, the diagnosis, so to pick up tissue you can pick, and the thing about cancer is that you have to have the tissue, and you have to look into the tissue and confirm that what you are dealing with is cancer. Now, the technology that we have now is such that we can confirm the various cancers, because there are special stains that you can do and special tests that you can run on tissue. So you need to train the people who are going to be carrying out this. So, and this is where we have a bit of problems in this country. The numbers of the pathologists in this country is very low. And the pathologists also, there are various types. There are those that are into histopathology, and then there are those that are into other types of pathology. But for histopathology, you find that the numbers can be less. But of late, we've started training, and we have more and more people that have come out from training that are taking up positions in the various parts of the country. We have pathology being done in Kitwe, Ndola, Kabwe, Lusaka, and Livingstone. We send our people to go and do pathology there. And then there are other solutions that people have come up with, where like Katete Hospital, they send their tissues abroad, and then they get the results, you know. And then of late, we've seen a lot of private participation as well, which we should encourage. There's a lot of private pathology labs around Lusaka, but the only thing that they like being in Lusaka. But if they can go out there, you know, they can help society a little bit more. But the turnaround time for processing this tissue is where the issue is. Remember that they are getting a lot more tissue from out there, especially on the government side, and to read this, it takes a long time, and obviously there will be those delays, but we are improving with time.
Excellent. Doc, after you've diagnosed, you know, the next critical stage is to break the news, you know, to the person in question, which can be traumatic, you know, knowing that, you know, what is on the mind of people is, I'm going to die, you know, because cancer is terminal. How do you break the news? What is the process?
So, like I said, you know, we're not supposed to say that cancer is terminal. It's never terminal. Like I said, we can do a lot. You know, some people can be cured. You know, like we can cure most of the cancers. 1/3 of the patients can be cured. Probably 1/3 you can control it. They can live long. Probably 1/3 is what you have with who you are going to manage, you know, their symptoms and control maybe their pain or bleeding, like that. But what is important is that you have to confirm your cancer. In cancer, you have to be sure with your diagnosis. So the tissue is an issue for us. So you have to make sure that you have the diagnosis, and then if you have the diagnosis, before people, you know, they never used to give, you know, it was a paternalistic way of doing things. You don't want to tell your patient what they have. But now we know that it's good to tell the patient what they have. And you have to be, you know, you have to be conscious of how you are going to break down, break the news, you know, to the patient. The environment should be good, you know, and probably you should have, you know, maybe a relative nearby, and sometimes we have a nurse, we have someone from palliative care, you know, like a team, and for someone from social work, so that you can try to explain to the patient. And some people, where it's difficult, we link them to fellow patients as well, to try to help to give this information. But a cancer diagnosis is not an easy diagnosis. But we have to tell the patient, because remember that someone who knows what is happening to them, they are going to comply with what you are going to do with them. But it's something that you embed in your daily work as a doctor, that you have to be dealing with this bad news. And you know, what is bad about Cancer Disease Hospital is that it's called Cancer Disease Hospital.
Absolutely.
You understand? So if a patient is coming, even when they are coming through, they already know, you know, they will know that they are dealing with cancer. But we have to be, you know, we have to encourage, you know, the patients about the the bad diagnosis, and that we can do something about it, you know. And in most instances, there's something that we can do. Even those who are very advanced, there's something that we can do. Always, there's something that can be done.
All right. Now let's run through the treatment, you know, from the doctor's side, the response from the patient, and general management.
Okay. So, in cancer treatment, and we've been developing systems over time. So, in cancer treatment nowadays, we encourage what we call multidisciplinary approach. So, we do not you know, one person to decide for the patient. And like I said, we want the patient to participate also in the process as well. So we'll give as much information as possible, and then as a medical team, we'll have a group of doctors to decide on what treatment to give this to this patient. So most of the time, like I said, there will be different types of health workers. There will be the palliative care team, there will be the pathologist, there will be the oncologist, there will be the radiologist. All these form one team, and then you can decide on how you are going to proceed with the patient. So we have what we call tumor boards, and this is where we discuss the patient condition. Remember that it's not just the diagnosis that we are treating a human being. So this human being, you know, we can have the same stage of cancer, but we are different people, and with different maybe comorbid conditions, or maybe even the state in which we are, the health status that we have is different. So when making that decision, we look at all those facets, and then we come up with a treatment plan. So most of the time in cancer treatment, we do not use single modality. So we use multiple modalities for most of the cancers. So there's different modalities of treatment. The first one is surgery. So with surgery, that's what we use to make a diagnosis, to pick up tissue and send to the pathologist. The pathologist will give us the diagnosis. With surgery again, in some cancers, say breast cancer, you need to do some form of surgery. Probably take out part of the breast, or even take out the whole breast, depending on the stage. And then you have to take out maybe tissue under the armpit, which can be also involved in the disease process. And then sometimes the tumor is too big. You can decide that instead of starting with the surgery, we can start with another modality. You know, so surgery is one modality. Then the next one is chemotherapy. Chemotherapy, the indications for chemotherapy, there are diseases that are purely treated with chemotherapy, like the hematological conditions like leukemia, lymphomas. Those ones you just give medical treatment, which is chemotherapy. And of late, the chemotherapy is becoming, you know, smarter, like I say, like I should say. You know, before we didn't know the pathology that well, but now we know the pathology. We know that breast cancer is not one type of cancer. There are various types. We can group them, and even the responses are going to be different. So when it comes to chemo, it's becoming smarter in the sense that it's well directed only sometimes to tumors. You understand? So there's what they've developed, you know, the type of chemo what we call monoclonal antibodies. A clone is just one, you know, like it will attack a set of cells that are similar, you know, coming from one parent. So there's what they've developed, what they call monoclonal antibodies. They've developed, you know, special molecules that will attack certain elements within the cell, and sometimes these drugs are less toxic than the previous drugs that we used to use, you know. But chemo in itself is quite rough, and you have to tell the patient that chemo is quite
the
rough.
side effects.
The side effects, yeah. And we tend to prepare the patient for the side effects. So the side effects that worry us a lot will be vomiting, nausea and vomiting, because the patient can lose a lot of weight and they can't pitch up for treatment anymore because they are vomiting a lot and having that nausea. But I can tell you now that we have very good drugs that can stop that. We rarely find patients having nausea and vomiting these days in oncology centers because of the nature of the drugs that we have. Then the other thing that would distress the patient, especially the female ones, is the hair loss. Yeah. So
why does that happen?
Hair loss will happen because the anti-cancer drugs, the anti-cancer drugs themselves, they attack the fast-growing tissues, and all those fast-growing tissues, including hair follicles, the hair follicles are quite, they are dividing all the time. So because we have given chemo, they will be attacked by the chemo. Just like the lining in the alimentary canal is also fast growing and growing all the time, just like in the mouth as well. All that will be attacked by the chemo, and then those cells will deplete. And when they deplete, that's what you see, like falling of hair, having sores in the mouth, having sores in the bowel, like that. That's why it happens. Yeah, and then the other thing that is worse than the other issues is where now you are causing the immunity for the patient to go down. Yeah, because it attacks another growing tissue, which is the bone marrow. And if you remember, the bone marrow is a source for red cells. It's a source for the white cells that help you to fight illness. And then it's a source for platelets that stop you from bleeding. So you can develop all these complications: anemia, you can have low immunity, and you can bleed because of the treatment that you are receiving. So, but nowadays, when it comes to the white cells, again, we have become smarter. We have boosters for white cells. So we'll give you the chemo and we'll put you on boosters, and the white cells will never go down.
Brilliant.
Yeah. So this is what we do, and we have those drugs.
What about these other interventions like herbal? The cell in all these outlets in the world. What would you say about that? Is it advisable? Do I buy that, or do I go and check with my doctor before?
You have to check with your doctor. It will be better to check with the doctor. And I can tell you, I personally, I do not encourage patients to use that sort of medication.
Because you know very little about it.
I don't know, I don't know anything about those medications. But what it is that the drugs that we use, they are informed by evidence.
Right.
We'll look at a number of patients, we'll do clinical trials, and then we'll come up with evidence on how to use that drug. But what I can say is that the use of herbs, which I have seen, and I hope my patients won't say that I'm saying, I'm not pointing at any of my patients. I've seen it in so many people, because people sell what they have. I mean, they'll say, no, this is herbal, very little side effects, or zero side effects. There's nothing like that. And we know that herbs can be very toxic.
Absolutely.
Yes. And people have died because of use of herbs, especially knocking out the kidneys, knocking out the liver. And I had one patient who came, and every time he came, his kidney function is going down. And I had to ask what else they were taking. And I discovered they were taking herbs. Immediately,
you removed that.
I removed that. They improved tremendously.
Brilliant. All right. Before we go on break and see if there are any messages coming through or the phone, we've talked about management from the doctor's side.
But I haven't finished on the modalities.
On the modalities. Please go ahead.
So I mentioned the surgery, there's chemotherapy, and then there's radiotherapy. Radiotherapy is it's a form of local treatment where we use, high energy X-rays that are going to kill the cells, the cancer cells. Now, cancer cells are dividing very fast, and they don't repair very well. So when we give radiotherapy, what it's doing is going to damage the DNA in the cancer cells, and because they don't repair very well, we give radiotherapy over a course, and we give time for the body to recover. If you've seen, we give most of the time, like 5 times in a week. We don't give on Saturday and Sunday, and we are trying to make the body recover. But the cancer cells won't recover very well; they will die out, and this is why we are giving radiotherapy. So we call it fractionation, where we're giving a smaller dose per day, like that, instead of giving a huge dose. But radiotherapy also has its own side effects. But that's another modality that we have. And then we have other modalities as well, like cryotherapy, where we freeze and we can kill, the cancer cells. We can use thermal, heat, and we can kill, cancer cells like that. And then most of the time, like I said, we are going to combine these modalities. So for one condition, for example, when we are treating breast cancer, sometimes we give radiotherapy. We'll start with, say, chemotherapy. We'll do surgery. We'll give radiotherapy like that, or we'll start with surgery, chemotherapy, and then we'll do radiotherapy like that. And then there's also, in the chemo maybe context, we give hormonal treatment as well. So this is how we manage. So most of the time, it's not one modality that we are using, but multiple modalities, and that's why we have to make that decision as a team, not as a single doctor.
Right. The emotional side, Doc, it's very critical. How does a patient manage the emotional, side? Is there anywhere I can go, that I can be assisted in terms of therapy of the mind?
Yes. And this is why, like I said, on each of the multidisciplinary team, we have all these various groups of people that are supposed to be involved in the team. So there's those people from the social side who are going to assess, where you can go, they will assist you probably on how you are, they will understand you first of all. Where do you come from? Do you have enough money for the treatment? If it requires money, what sort of faith do you have? And which people can you associate with? And then there's organizations that work with us within the hospital. We have psychosocial people within the hospital who can try to help us, with sorting out, psychosocial issues. And then we also encourage religious people to visit and visit the patients. Some people are highly religious, and they will resort to looking at God. But always we want them to undergo the treatment.
Absolutely.
And follow their belief as well.
And strong will is very important.
Strong will is very, very important. And this can be gotten from the people who have been treated before. Those are good support groups for each cancer. For example, in breast, there's those patients that have been treated before. They can help the patient. So we have them within the institution. Some of them, in the morning, they are teaching.
Brilliant.
They are teaching the patients, about the condition, what they will undergo, and we encourage participation as well of the patient.
What about you doctors? You're also human beings.
Yes.
I mean, the emotions also involved,
Yes,
especially when you see a patient really, suffering, again, how do you manage your own emotions?
So this is where, even as doctors, we also we need also to be looked after.
Yeah.
Yeah, and we are human beings that we are affected by what we do as well.
Yeah.
you know, there are things that we encourage doctors to do as well. You know, maybe, you know, apart from just doing your work, you should go on leave from time to time, you know, to go and do other things, like stay away from work and do other things. And then the sport that we encourage people to do sport. We try as an administration to encourage, you know, people. We even bring, you know, aerobics in the institution for people to participate in.
I've seen a number of my doctor friends playing golf.
Yes, and
it's good for the mind and the body.
I play football still at my age, so and I run a lot. So there's a lot of things that we encourage our people, but we need to be looked after as well.
Absolutely, absolutely. This is Frank on Camnet. It's the month for cancer, and that's basically what we're looking at this evening with my guest, Dr. Louis BANDA. We're going on break, and if you've got any issues to raise with my guest, oh my God, you're free to do that. Join us very shortly after this short break.
Camnet TV is becoming big and better. You can now watch Camnet TV wherever you are around the world, simply by downloading the Camnet TV app. With Camnet TV app, you only use less bundles. Camnet TV, not just another channel.
Do you have an extra car? Then make yourself extra money. We would like to put that car, yes, that car parked there, to good use to make you extra money on the side just through its service while keeping it safe and secure. Call 0765 02 3883 to register your vehicle with us today. Delpo Services, service beyond satisfaction.
It's Cancer Month, and we're dedicating this program to various forms of cancer. My guest this evening is Dr. Louis BANDA, from the Cancer University Hospital. If you'd like, to call us now or send some text messages, please, do so now. Before we do that, we really have alluded to a number of, issues, Doc. Let's look at the challenges, that the hospital is facing. Human resource, the technical, side, budgetary allocation. What is the situation prevailing?
Okay. The major things that we are facing as Cancer Disease Hospital, we include obviously manpower. We don't have enough manpower, and when I say manpower, not only those that are specialized in cancer, but also the other workers that help to keep the place running. So we just need to bring in more people so that we can give better service. And what is good about us now is that we are able to train. And you know, we started training the radiotherapy technologists on our own, and our program has grown, and now it has become very attractive. The International Atomic Energy Agency, the IEA, is sending, you know, people from other countries to come and train with us. We can also train the nurses. There are programs that have started locally that are training nurses under the University of Zambia. We can also train doctors now.
Oh, brilliant.
And even under that training, the International Atomic Energy Agency is sending people to come and train under us. We've trained quite a number of people from other countries. So with manpower, we can build, you know, especially the specialized ones, we can try to build the numbers. We are yet to start training medical physicists, but we have capacity to do that. And the other thing that we has given us a lot of problems now is the issue of equipment. You know, our equipment was installed in 2006 thereabout.
That's a long time.
A long time
Things
now.
have changed.
Yes, and things have changed, and our equipment are having all sorts of issues. They are almost towards the end of life, and we need to change them. And they keep, you know, giving us, you know, a lot of problems. Most of the time they are not working. They need to be repaired. Others have become obsolete, and we have to change them. So we need to reinvest at Cancer Disease Hospital for us to continue offering a good service, and that we have established, and we are trying by all means. And with a new government in place now, we have stated the case of what is happening at Cancer Disease Hospital, and they are highly supportive. And I'm sure soon we'll have you know, newer equipment. There are other solutions that we have that we can use to come up, you know, to improve the situation at Cancer Disease Hospital as well. And we are trying other means as well where we can get at least newer equipment at Cancer Disease Hospital. The other issue is that Cancer Disease Hospital is the only hospital offering cancer. In itself is a problem, in the sense that we know now that when you look at the National Cancer Register, the number of patients with cancer as of 2020, we had over 13,000.
Amazing.
You know,
that's a huge number.
13,000, yes, patients. But we know again that over the last few years or so, the number of people coming to Cancer Disease Hospital is only about 3,000. So where are these 10,000?
The other 10,000.
You know, and this is worrying. And you know, if all these people were to pitch up with the number of you know, radiotherapy equipment that
you wouldn't even cope.
We wouldn't cope, And even the number of surgeons that we have at Cancer Hospital to operate, it will be a problem as well. So we need more, you know, we need more people, you know, we need more, you know, more centers, I should say. We should decentralize this service so that we can do better. There are plans on what we call the phase 3. If you've heard about it, that we want to decentralize to Ndola as well as in Livingstone. This is under phase 3 and upgrade Cancer Disease Hospital. So there are those plans that we are waiting. And then there are other solutions that we've come up where, you know, we can, you know, change some equipment at Cancer Hospital as well, and maybe even improve on the service at Cancer Disease Hospital. Then the other issue is about, you know, the issue of the budget. The budget that we have, you know, just for drugs. And this is where we've gotten a lot of flack from the public in the sense that we are failing to give all the anti-cancer drugs. The fact is that, the budget does not sit with Cancer Disease Hospital.
Right.
The budget sits centrally, and, from the monthly grant that we receive, we can only use about 10% of that grant to get our drugs. And cancer drugs are very expensive.
Yeah.
We are given about $1 million plus, as a monthly grant. And over the years that have passed, sometimes the grant doesn't come, and that's a problem in itself. But of late, consistently the grant has been coming, but we need that central procurement of the medicine. And I can say that not too long ago, we were trying to forecast and quantify of the needs that we have in terms of consumables and cancer drugs. If we were to have what we require, you understand, everything, the budget is quite high. It will come almost to about probably in terms of dollars, because most of it is imported, and the people who are helping us to do that, we are using dollars. It came to almost $5 million, just on consumables and drugs.
It's quite high.
Yeah. But remember that we can escalate the treatment to that level, but we can also bring it down. We can also bring down the cost in the sense that we can give the basic requirements. If we're giving the basic requirements, probably the budget will come down, tremendously. And this is where, remember, like I said, there are all these new things that we have to use, monoclonal antibodies, and then the type of masks that we have to use, and other consumables as well.
Right. Before one or two questions, let's see if we can have any. Do we have any messages, on the screen? Do we have any? No messages? Right. We've talked about the financial, outlay, which is very, very high. Do patients pay to access the service?
Okay. It was a matter of policy that the cancer services should not be charged for. So chemo and radiotherapy is not charged for. Now there's been the issue of NEMA.
Right.
NEMA has come on board.
Yeah.
And NEMA,
insurance.
They've assisted the patients who are under NEMA.
Yeah.
And they've given them access to anti-cancer drugs. If we fail to get them, some of those that are under NEMA, they go and get the drugs under NEMA from the pharmacies. So that has improved on the anti-chemo, anti-cancer supply. But in terms of people paying for the treatment, the actual treatment, which is chemotherapy and radiotherapy, they don't pay. Okay, but they will pay for a bit of investigations, a bit of minor surgical procedures like that. They will pay for it, but not for radiotherapy and chemotherapy.
Before you find a word, the commemoration of this month, how are you managing? What activities are there?
Yeah, so last week we were in Indora. So we were there the whole week, doing the awareness campaign, and then on the 4th, which was February, we had the actual commemoration of the World Cancer Day, which falls on the 4th of February. And then there are more activities, campaigns that we are going to have up to the end of the month. Yes, and then on the same day there was also World Childhood Cancer Day as well. And I should say that childhood cancers, like I said, they are special cancers. They are not like we don't want to treat childhood cancers like adult cancers. They are totally different. Most of them are hereditary, and most of them are quite curable.
Yeah.
But I should state that in very developed centers in the world where they're treating childhood cancers, you find that 80% of the cancers are cured.
Right.
But in our case, in these parts of the world, we are only about 20% cure rate.
It's too low.
Too low.
Yeah.
So we need to raise, the cure rate to the level of 80%, and we can do that in the sense that if we can do most of these awareness campaigns,
Absolutely.
Diagnose early, and have access to good, therapies. And I should state here that we are very lucky as Zambia, because we've been picked as one of the countries that are going to have access to drugs, for pediatric drugs.
Brilliant.
For cancer drugs.
Brilliant.
And that access is an access, to medications, and it's going to start beginning this year.
Yeah.
And I'm sure it will be a game changer, because it will be like what you see under Global Fund.
Absolutely.
For HIV as well. Yeah. So if we can have that, I'm sure there are solutions that are coming up, and the picture will change as we go. And I'm happy that we've been picked by WHO as well to look after, the pediatric cancers. And at the moment, as a country, we are coming up with the National Cancer Control Plan. The one that we had started 2016, ended about 2021, and then we need another 5-year plan as well. And it's only now that we are trying to put it together. And I'm sure the next plan will be much better than the previous plan, in the sense that the previous plan, we only prioritize 4 cancers, but all cancers are important.
Exactly. Just very briefly, in a minute, so your final word, to the people out there who are listening, watching. Some of them were really frightened of what we've been discussing, today. Your just final words.
Okay. What I should encourage people is that we have to be health conscious as a nation. It's important that we know that some cancers are purely, preventable. Cancers like cervical cancer, we have resolved as a country that we want to eliminate cervical cancer, and there are ways of doing it. So, like I said, number 1 cancer is cervical cancer. When you come to cancer disease hospital, up to 33% is cervical cancer.
Yeah.
Now imagine that if we eliminated that number, there will be very few people coming through. And it's something that is doable. And we've seen the results in other places where they are doing everything. They are vaccinating, they are doing the screening, and they are doing early diagnosis and treating these cancers. They disappear. Yeah. But one thing for sure is that cancer is something that is, quite common, and cancer in some instances can be cured. Yeah. And the people should try by all means to come, no matter what, they should come to cancer disease hospital so that they can be assessed. They can see an oncologist, at least for the assessment, and then for the plan for the treatment as well.
Right. Are you worried that the advent of COVID is taking away the focus from cancer?
Yeah, to some extent it does, and also I'm sure it's affecting also the presentation to hospitals. Some people are scared to go into health centers because of they don't want to pick up COVID, and
absolutely,
and it will show, I'm sure, going forward, where we find that there will be those numbers coming down, where we're doing well, those who are going for screening and they never reached up for screening. So it's something which is affecting us.
Doc, thank you very much for appearing on our show, and thank you for the great job you're doing for our country.
Okay, thank you very much.
Okay.
Okay.
That was Dr. Louis Banda from the Cancer University Teaching Hospital. We dedicated this program to the Cancer Month, which is this month, February. Thank you very much for watching. Like I keep on saying, do your very best, and God will do the rest. On behalf of my crew and my producer, Pastor Chiluba and Mrs. Chiluba, have a healthy night and good night.